Creating an environment for healing is, of course, really paramount for healing musculoskeletal or orthopedic disorders. A lot of people think therapies for disorders are about what you add to your life to fix the disorder, but a lot of it is also what you subtract or temporarily change during the therapeutic process to enhance the ability to heal, or not even enhance the ability to heal, but allow the ability to heal. Picking at the scab or opening the cut are analogies that I use for patients all the time, and I think it's especially apropos for neck, mid-back, and low back disorders because of our lifestyle factors that we've been habituated to for not just years, but usually decades. If we take a cut on the back of the knuckle, in order for that cut to heal, for the skin to regrow, for it to close up, a scab to form and then to fall off, and then for it to be as good as new, you cannot keep flexing that knuckle or bending that knuckle while that scab formation is in process. So that's where we get the picking at the scab or opening the cut kind of metaphor. Patients know this. They do know that that makes complete sense, that you can't keep opening the tissue and expect the tissue to close and to heal. And to a similar extent, people understand if they sprain the ligaments on the outside of their ankle, we need to give it a period of rest, not excessive, but a period of rest where we stop putting load on those ligaments, we stop stretching them to their fullest extent, we stop loading them with certain activities, maybe running or jumping, for example, for a therapeutic window of time while we apply other therapies to let it heal. And sometimes you just need to rest it. You just need to give it that environment for healing without even adding things, and it will heal naturally. Kind of like the skin example. You don't necessarily have to do a lot for that skin to heal correctly. Covering that wound with a Band-Aid or something else, or maybe even in bigger gashes, putting a popsicle stick and taping your finger to that so you don't bend it as much. Doing types of things like that can be conducive to healing, but sometimes you can just do nothing but understand the principles of what you're not doing so it can heal. So I think people can understand those examples, that yes, you sprain your ankle, you can't run for the first week or two, or maybe longer, depending on how egregious the sprain was. When it comes to low back disorders and neck to the same extent, so many disorders of low back and neck I find are mechanical joint derangements, which means moving into a specific direction or two repeatedly will fix the disorder while we temporarily minimize, reduce, or avoid movements in the exacerbating direction, movements in a direction that will not facilitate healing. Part of healing these joints is, for example, going into extension for many people and minimizing flexion. But because so much of our lives are in flexion or forward bending, that can be a really difficult task for people. So what I impart to patients is that let's say a hypothetical patient, which is the majority of spinal patients who have mechanical disorders who need extension, or at a minimum get worse with flexion, I want them to know that if they repeatedly go into flexion, either bending excessively throughout their day or with specific workout routines under load, or bending in a flexed posture with sitting, especially slouch sitting or sinky seats or bucket car seats, that's like picking at the scab. And so why would we expect you to heal if you continue to do that while you're going through the therapeutic process? Studies show that Westerners bend thousands of times forward per day, so we're not going to take that away from a person's life. We may have to minimize that, but it's rare that I'm telling a patient to minimize how much they bend forward in a day with their back or their neck. What I am telling patients on a regular basis, however, is because we're not going to try to whittle down the number of bends you do throughout the day, let's minimize the amount of sitting in bending in a bent position that you do throughout the day, especially slouched sitting. When I have a low back derangement or neck derangement, I think a big reason I can get away with doing fewer repetitions of the therapeutic movement throughout my day, not necessarily every 2 hours like I instruct patients to do, is because I really understand how to prevent opening the scab. I really understand my biomechanics. I learned many years ago when I started learning more about Robin McKenzie's work, how important upright posture can be to the load on the spine and the discs in particular. So if I have a problem, I'm not going to keep opening the scab, and so I probably need less therapeutic advantageous movements. For example, going into retraction extension of the neck, I don't need it necessarily every 2 hours, because in the intervening 2 hours, I'm going to create an environment for healing and stop flexing and opening that cut. That's why I err on the side of usually asking patients to do a lot of repetition of the extension, or of the extension with hips off center, or of the left side bend, because it's very hard for most of my patients to understand what slouch sitting is, or how often they'll get into a project with work on a laptop or on their phone and spend hours in neck flexion. So the more I can educate people on that process, the faster we will see resolution. But there's lots of patients who actually think they're sitting upright, but when you go over and you put your hand on their back and you push them into actual upright posture, they'll notice that, oh, I thought I was sitting in a neutral spine, but I was actually sitting with a slightly rounded spine. And again, that pressure over time can add up. So opening the cut, picking at the scab, they're central tenets of fixing low back and neck mechanical joint disorders. And for many patients, it can take a while to click in. but that's part of the process. If it's mechanical, there's going to be a movement or two that we need to do on a regular basis, and there's likely a movement, maybe two, but usually just one, that we need to temporarily avoid. And a lot of that will spill over to the maintenance program or the lifestyle habit changes that we make. For example, learning how to sit while you're temporarily fixing a disorder can become a lifestyle maintenance program for reducing recurrence or minimizing recurrence of the disorder down the road. So changing those habits is not just hard for a temporary time period and not having a long-term payoff. It's having a long-term payoff because now you've learned how to treat your back with sitting for the long run. Again, hopefully minimizing return or recurrence of the injury, which is what we see. If you reduce the lifestyle factors that likely led to the disorder, then you're going to reduce them from returning. So think about these concepts when you think about orthopedic disorders. It's not just for mechanical joint disorders. Obviously, if there's a tendinopathy, it's kind of obvious to patients. We're not going to let you go run on an Achilles tendinopathy or play tennis on a lateral elbow tendinopathy if it creates so much pain that you're out for 2 days, because that's picking at the scab too. It's not letting it heal. Or if you tore your muscle on a Monday, we're not going to let you use that muscle a lot on Tuesday, Wednesday, Thursday, or for however long we need to, while that structural lesion heals. Ligament sprains, muscle strains, tendinopathies, those tissues also need to be at rest or minimize the load. We need to minimize the load so it can heal. And those examples, again, are kind of more understandable to patients, but the joint loading is really hard for people to understand because it's just such a part of their lives that they never had thought about before. They can understand not running, not playing tennis, but it's hard for them to think about not slouching and putting a flexion load through their spines. So as clinicians, or as personally as myself as a clinician, I do my best to really make that point to the patients because it can really impact and delay progress if they're even being really diligent with the home program of the therapeutic movement, say doing neck retraction every 1 to 2 hours, but in the intervening time, they're going into neck protrusion. They're just not going to see the results that they want. And it really frustrates the process. So I have to be very clear about what I think they need to temporarily do on a regular basis and what they need to at least temporarily avoid to, again, create that environment for healing.